Hello again. This is Stephen Bernstein, Global Chair of McDermott's Health Industry Practice Group. Welcome back to the second episode in the special three-part edition of our monthly podcast, Governing Health, on the role of the state charity official in regulating nonprofit healthcare. In this second episode, we begin to engage our charity official panelists on how the evolution of nonprofit healthcare impacts their responsibilities and state nonprofit law. And to moderate the discussion, I again turn to my partner, Michael Peregrine, the host of Governing Health.
Welcome back to episode 2 of this special edition of McDermott's Governing Health podcast. I'm Michael Peregrine, your moderator. In our first episode, we began a conversation on the basics of the Attorney General's oversight of the nonprofit healthcare sector. In this second episode, we're going to wrap up that conversation and begin to consider how Attorney General oversight is affected by the transformative shift in the traditional healthcare delivery model. Now let's return to our conversation with Karen Gano, Mark Pasella, Bob Carlson, and Jim Sheehan on the role of state charity officials in regulating nonprofit healthcare, and our particular focus on how that's affected by the current evolution of the industry. Karen, if Dr. Ezekiel Emanuel tells us that the inpatient healthcare facility is dead, if that's the case and we're moving to different uses of the building and the healthcare service, do you get concerned about what they call mission drift and about the tension between donor intent and a change of corporate purpose with charities?
Yeah, it's an issue that we see a lot of activity in. For instance, when the large healthcare organizations are beginning to take on all aspects of healthcare, and when one of our major systems in Connecticut took over a rehabilitation center to offer rehabilitation center services, they began to take over most of the rehabilitation facilities in the area, in that region. And they took over an Easter Seals facility that had been operating for 55 years. It was one of the very first Easter Seals facilities. And as a mission, as a part of its operations, that healthcare system did not offer occupational therapy. So that it only offered other types of rehabilitation. And the Easter Seals approached us and said, we for 55 years offered that, and as healthcare systems began to change in the rehabilitation that they offer, we are taking over more of that occupational type of therapy. And we don't believe that all of those assets, and they were 100% gift assets, should go to the large healthcare system. We believe that some of those should go to Easter Seals. And we did an in-depth investigation, and we agreed with them, and that included significant real estate assets, all of them gifts, as well as significant money and endowment assets. So the thinking about where those assets came from, what they were used for, is something that, particularly when they're gift assets in the community, is something that the healthcare system had not considered. They're thinking about their own mission. They're thinking about, they had observed all of the appropriate governance and legal requirements in taking over that rehabilitation center. They had transitioned those services that rehabilitation center offered, that the healthcare system no longer offered, in an appropriate way, but they had not thought about these assets. And we see that both in large and in takeover of smaller systems as well. Here in Connecticut, we often had donors in many of our 169 towns which donated money for a hospital there in the early part of the 20th century or even the late part of the 19th century. And those hospitals are no longer functional. They've been altered over the years, but then as a large healthcare system acquires them, we're finding they're not giving attention to those gift aspects or those transition aspects in terms of the mission that was intended or the donor intent, where there are restrictions to the type of services that were intended to be provided in that community.
I would offer that we're seeing the same thing in Pennsylvania. Hospitals and hospital systems seem to be branching out in ways that they hadn't in the past. They're beginning to acquire retirement homes that have those various stages of care, independent living, skilled nursing, hospice facilities, and a variety of other endeavors that all tend to relate to healthcare and have the clear appearance of being able to shepherd patients, if you will, retaining patients in that healthcare system. They've been acquiring physician practices for years and years, but this is, I think, just a continued expansion of their reach.
Jim, let's turn to you. Your office has been taking a look at some of the largest nonprofit healthcare transactions in the country. What are the key things that you need to see from your office before signing off?
So we are seeing two specific kinds of transactions. One is the conversion of nonprofit managed care entities, the sale of their assets to for-profits, and conversion of the selling organization into a charitable giving foundation as opposed to an operating foundation. And the second category are the decisions by nonprofit hospital groups, entities, to sell off specific assets. And Karen talked a little bit about that in terms of specific requests. In New York, there's a more general statutory requirement that any sale that takes place of charitable assets, and that's, the managed care plan or the nursing home, has to be for fair consideration, and it has to be in the best interest of charitable beneficiaries and we're served by the organization. So one of our concerns, for example, looking at nursing homes, is what's going to happen to the people who are currently resident of that home and the people who historically have gone to it. Now, there are all kinds of business reasons why it makes sense for hospital systems to get out of the nursing home business. But what we find is they engage a Wall Street person or an investment banker and say, get us the maximum amount of money. And neither the board nor the investment advisor is considering what is the impact on the people who live in that nursing home and the patients who are likely to come to it. And we face that issue in New York with a nursing home operator who bought a nursing home and 6 months later sold it to a condo developer. And so that's encouraged us to think about and to ask of boards, what provision are you making for the patients, and how does this serve the underlying mission? And it doesn't mean just take the money from the sale of the nursing home or the other facility and elevate it up to the parents, because they often have very different missions. The second issue that we are facing is in a recent case involving the sale of the Catholic healthcare plan in New York to Centene Corporation, a for-profit corporation from Missouri, for about $4 billion. And in that case, one of our concerns was, tell us how the sale of this entity, that is to Catholic healthcare, serves the interests of beneficiaries in the same way that you have been serving the interests of beneficiaries by covering the entire state, by providing hard-to-get care, by taking care of ethnic minorities and language minorities. And they did a solid job of putting that package together, both on the sale side and on the purchaser side. The next question we wanted to make, so that issue, one of the things we've done with that transaction, and after it closed, we required Centene to engage an expert over the next 3 years to take a look at, in particular, the Medicaid program and to see that quality is maintained and access is maintained at the same level that existed before the sale. We also look very closely at the foundation. Again, it's the board's decision about how the money will be spent. We wanted assurance that there was a system in place to assure that the beneficiaries who had been the beneficiaries with the prior health plan would also be the charitable beneficiaries of the foundation, and with a focus primarily on caregiving as opposed to health policy. The next issue to us was golden parachutes, and these are a challenge in every large healthcare transaction because hospitals and health plans look a lot like their for-profit competition, but the challenge we have is how to make sure that charitable assets are not being used to pay off insiders, which is a different standard than is applied in the for-profit sector, and that they're fully disclosed in the transaction because we want to make sure that the officers are acting on behalf of the charity and the charitable beneficiaries in their decision to sell. And that particular issue, so we've required transparency in what the payments were. We do recognize that there is a significant interest in continuing with existing management during the transition period that is related to a sale, and that did happen in Centene and Catholic Healthcare. And it is reasonable to give somebody a severance payment at that point if they're no longer be working there to make sure they stick around. We also found that there were significant differences between the pension plans available to nonprofit executives, which are richer, interestingly, than those available to for-profits. So a true-up can involve that kind of issue as well. That is, the conversion from the not-for-profit pension plan or deferred payment plan to a for-profit plan. But each of these issues in the larger transactions, the board needs to ask itself, how is this promoting the mission of the organization, not just the fact of the sale itself, but what's going to happen after the sale occurs.
Hold that thought. That's terrific. We're going to take a quick break right now and get back to more on the role of the state charity officials in regulating nonprofit health care. Now let's return to our conversation with Karen Gano, Mark Pasella, Bob Carlson, and Jim Sheehan on the role of state charity officials in regulating nonprofit health care, and our particular focus on how that's affected by the current evolution of the industry. Mark, you've got a very thorough conversion statute in Pennsylvania. What concerns do you have? Are they similar to what Jim and Karen and Bob have been talking about?
Yeah, I think they are, Michael. It's for us, it's obviously the loss of charitable assets, the diversion of assets. You know, people that want to convert from nonprofit to for-profit, or if they want to sell to a for-profit, you know, the community is going to lose the benefit of that focus. That entity is now going to focus on profits. And so when we lose that community benefit, it can be a little troubling. For us, you know, we don't have the authority to substitute our judgment for that of the board, but we are obliged to ensure that the board has exercised its fiduciary duties of both loyalty and care in arriving at whatever decision they made in deciding to sell or convert. And so we'll look at the sale process, if it is a sale or conversion, to ensure that we're getting fair market value. A charity that wants to convert from a charity to a for-profit, in most instances, is going to have to redeem whatever that value is so that that value continues to benefit the public as opposed to the folks who may be the resulting shareholders or partners or interested investors or whatever. And then, you know, just a general question in terms of why do they want to do this? You've heard earlier the references to the obligation, the fiduciary duty of loyalty. That loyalty to the mission of the organization is pretty fundamental, and a matter of convenience or simply seeking or deciding to exploit an opportunity to reap some benefit might be objectionable by us. And if the board can't actually substantiate the valid reasons why they want to go forward with this transaction, we may challenge them and seek injunctive relief to try to prevent the thing from going forward. When we talk about the diversion of assets, the valuation, et cetera, that's one of the slippery things. If hypothetically, if an organization has a value of $250 million, the process that they would go through in terms of either converting or valuing that or selling it is going to be pretty critical in terms of giving us any confidence that we're actually redeeming the fair value, that we haven't left stuff on the table, and that the folks who are acquiring these assets post-closing aren't going to have a windfall. So we'd be looking pretty carefully at that sale process, looking at the strategic plan, what it is that's driving this decision. If they don't actually follow a diligent process, we're apt to press for expert valuations and other sorts of cost expenses and studies that could easily be averted if they had followed a very vigorous public offering, got competitive bids and that sort of stuff. I think that, you know, case law makes pretty clear that that's the best test of fair value or fair market value.
If I could, one of the other things that we're finding is that organizations that are in difficulty, one of their solutions is if they have 3 or 4 assets, they're going to put off the inevitable for another 2 or 3 years by selling off that asset. And it's not based, as Mark talked about, based upon a consideration of what's in the best interest of the shareholder beneficiaries. It's to preserve management's position or the board's position or the organization as opposed to the charitable mission. And we're seeing those kinds of sales of assets because there's so many changes happening in the healthcare sector relatively quickly that the temptation to just hang on by selling assets is significant.
Yeah. I mean, clearly, you had to follow Jim's comment. I mean, boards can wait too long, and they can lose whatever leverage they may have had in negotiations on any kind of a transaction. If they're upside down, if they don't have any value, if their debts exceed their equity, et cetera, they can really end up doing a very bad job for their community and stuff. I think Jim is correct. I don't think it's always necessarily the desire to promote the organization's best interest and, by logical extension, the community's. And this again goes back to the board. The board should be paying attention to what management is doing, what management is recommending, and challenging management to say, so what about these financials that are not looking all that good? What are we doing to turn this around? what do you have as a plan? The board ought to examine its own conscience to see if they have some ideas and stuff. But we've seen a couple of transactions in Pennsylvania that were pretty sad because nobody really acted in time. And as a consequence, we lose that value. When it's gone, it's gone. The incentives that might be in place, particularly when a for-profit is going to acquire, I think Jim is correct. The acquirer will often want to ensure that there's going to be a good transition, that they're not going to lose employees. They may make lucrative employment contracts available to try to get the support of the people who are managing the organization now or have influence with the board in terms of decisions that they might be making. So we'll look at future employment contracts and those kinds of circumstances. If at the end of the day it looks to us as if this is a decision that isn't supported by any valid exercise of due diligence, that they haven't really exhausted all other alternatives and that sort of stuff, as I said, we'll seek to enjoy the transaction. That's been very rare. We typically simply have to start this dialogue and express our concerns, and typically we've been able to work out less tragic circumstances. But it's a concern for sure. Conversions are all about value and motivations and what the impact is going to be on the community when all the dust settles. Charities will typically try to hold on as long as they possibly can to provide service lines that don't make money. We've seen when for-profits or the conversions into for-profits, that commitment obviously doesn't exist. And neonatal intensive care units may close, burn units may close, obstetrics and gynecology may not be offered in that particular hospital facility. So again, we really do count on boards to pay attention to what's going on, hopefully before things get that difficult and they feel they need to sell.
Let's pivot for a second from M&A to joint ventures. Bob, share with us your views on lessons learned and things that you look at when healthcare institutions, nonprofit healthcare institutions, engage in joint ventures for whether they involve new programs or services or maybe the construction of a new hospital. What supervision do you provide over joint venture investments?
Well, I guess we think St. David's was correct. The nonprofit must remain in control of the joint ventures. When we do review these, we want to see there's actual control with an emphasis on care, no excess benefit to any individual or the for-profit partners. But we understand we need to balance that with the need to reward and incentivize people who do provide excellent care to communities who might not always have access to that care. Have a long way of saying it depends on the actual situation. And the other part of the answer to this question is we don't review a lot of joint ventures here in Missouri. Under Missouri, our mandatory reporting and review comes in on change of life, so dissolution, merger, asset sale. And joint ventures don't always fit into that because you're sometimes often creating an entity or creating a partnership, as opposed to having an existing nonprofit have some form of change of control.
Let's turn for a second now to a hot area in healthcare. Jim Sheehan, innovation is a key word. So many healthcare systems, for all the right reasons, are beginning to pursue investments in innovative activity, whether it be pharmaceuticals, medical devices, new services or programs, and they're investing funds directly or through subsidiaries. When you think about this movement towards innovation as a state charity official, what comes up in your mind?
So one of the challenges that we see in the context of investments by not-for-profits, including universities and healthcare institutions, the law of charity is very clear on making investments. And the uniform, what's called UPMIFA, the Uniform Prudent Management Institutional Fund says you have to have a process, you should have a committee. If you have an investment advisor, you should have a contract. You should set forth what your investment goals are. A very structured process to make sure that investments are objective and careful. One of the challenges in organizations where the investor is either the entity or the major people within the entity is that it's a political process as well as a investment process. So one of the expectations we have is that there be a very rigorous process for assessing both initial investments and whether additional money is put in the same way you would look at any other investment. And one of the interesting cases in the last couple of years is the University of Louisville, where the same person was the president of the university and the president of the foundation and was also getting significant payments from the foundation and was participating in the investment decisions of the foundation. And as alleged in the complaint that was recently filed, the difficulty is that you couldn't separate out those responsibilities, and many of the investments were very much unsuccessful. So the combination of that political process, the role of management, and people's desire to believe that investments they make are better than others really requires a very objective and detached assessment of whether this investment makes sense.
That's great. Let's hold that thought for a moment and pick it up again in episode 3. Thanks for joining us today for the second episode in our special 3-part series on the role of the state charity official in regulating nonprofit healthcare. We hope you'll join us again for the third episode in this series. Remember, you can always access Governing Health episodes on SoundCloud, iTunes, and YouTube. Until next time, this is Michael Peregrine saying, thanks so much for listening.
Copyright 2018 McDermott, Will & Emery. All rights reserved. Any use of these materials, including reproduction, modification, distribution, or republication without the prior written consent of McDermott, Will & Emery is strictly prohibited. This may be considered attorney advertising. Prior results do not guarantee a similar outcome.